Our MEC Minute topic for February 2018 is croup. Croup is a illness that we see this time of year, particularly in children of younger age. And croup is generally a viral illness caused by a group of viruses called parainfluenza viruses, generally types 1 and type 3, but there may also be some other viruses out there that cause this. The infection causes generalized airway inflammation and some edema or swelling of the upper airways. And swelling of that upper airway mucosa is what results in a lot of the symptoms, particularly the stridor and croupy cough that we'll hear. The swelling is in the subglottic area, which is the lower larynx, so it's below the vocal cords. And there's narrowing there because of this mucosal swelling and edema. Typically, it's a short illness of 3 to 7 days, although if you're the child or the parent taking care of a sick child with croup, it seems like it's taking longer than that. And that barky cough that's synonymous with croup usually lasts about 48 hours, and we can reduce the duration of that cough and the child's respiratory symptoms by giving him a dose of steroids, which for us is usually Decadron or dexamethasone. For these children, what do we usually see on exam? The child's illness may be of various degrees of severity. The child could be mildly inconvenienced or be very acutely ill, and the child often looks uncomfortable and miserable, as do some of the parents. Symptoms are generally upper respiratory in character, so they have the croupy cough, they may have a runny nose, they may be drooling a little bit, they may also have a fever, they do have the barky cough, and if their symptoms are severe enough, particularly with associated stridor, they could have retractions of the suprasternal area or between the ribs. So often when I see a child with croup, I'll lift the shirt up to see what's going on underneath to see if there's any evidence of retractions between the ribs. Croup severity can vary anywhere from being mild to moderate, and the article that's part of this presentation looks at the cough, which can be occasional to frequent, stridor, which can either be minimal in a mild case or can be very loud with inspiration and expiration, and in the moderate severity, you can just hear it at rest. If you're looking at retractions of the suprasternal area, that notch at the top of the sternum, or intercostal areas, in mild cases of croup, you barely see any, if you see any at all. And for moderate, you can see it at rest, but the child doesn't look too sick. And then if they have severe croup, they often have marked or severe retractions where you can see a lot of indenting of the area between the ribs or above the sternum. In a child who's mildly ill, you really shouldn't see much distress or agitation, although the child may look a little grumpy and sick. For the moderately ill, again, they don't look too bad, but the severely ill child with croup looks uncomfortable, can be agitated, or if it's bad enough, could have substantial lethargy and really may not be that responsive to stimulation. Those are children that look sick, and those are the ones we should have a high index of suspicion that they may need some airway adjuncts to supplement ventilations. Cyanosis is usually rare in croup. It tends to be more something that you see if the child is actually having some respiratory failure as a consequence of his illness. So if you see a dusky or cyanotic child with croup, beware, that child's in trouble. There are also some Croup Mimics that you need to be aware of. Bacterial tracheitis, it's an inflammation of the trachea. It is a bacterial infection, does require antibiotics, whereas croup is a viral infection that does not require antibiotics. Bacterial tracheitis, a child looks very sick, they have a high fever, and they don't really respond well to nebulized epinephrine. So when we talk about treatment and using nebulized epinephrine, a possible cause of a treatment failure could be bacterial tracheitis. It's not a very common illness that we would see. There's also something called a retropharyngeal abscess, which is an abscess at the back of the throat where there's an infection that needs to be drained surgically. There can also be a peritonsillar abscess, meaning abscess around tonsils. So if a patient still has their tonsils, you have to think about a peritonsillar abscess. Peritonsillar abscess is something you see in an older child. It's generally not in a child of younger age, since children with croup tend to have it between 6 months of age and 3 years of age. Epiglottitis, thankfully, is not as common as it used to be. When I was starting out in emergency medicine, the one thing we always feared in children with a croupy cough was epiglottitis. These children are very sick. They have a barky cough, but they look sicker than most or your average croupy patient. These children have significant toxic appearance. They can be drooling on themselves. They can be sitting up in that sniffing position trying to maintain their airway. Epiglottitis is a bacterial infection. The epiglottis itself is infected and inflamed, and if it becomes severe enough, can result in airway obstruction. In the olden days, if we suspected epiglottitis, we would do an X-ray of the neck, or we would have the patient taken to the operating room, where anesthesia would intubate the child under controlled circumstance in the operating room. Epiglottitis tends to occur in children a little bit older age than croup. Epiglottitis, thankfully, is very rare these days because of the vaccine, the HIV vaccine, which almost all children now get. It is a vaccine against Haemophilus influenzae, which is the bacteria that causes epiglottitis. When I see epiglottitis anymore, it's usually once or twice a year in an adult who's lost their immunity. So I've seen this more in an adult in the past 15 years than I've seen it in a child. Another thing that you need to think about as a croup mimic, particularly in a toddler or a child that's crawling around the floor, is ingestion of a foreign body. They could be crawling on the floor. They find a Lego or some other small toy. They put it in their mouth, and it causes an airway obstruction. These children can look croupy. They can have their croupy cough. They can have choking episodes and wheezing. The key thing is these children don't have symptoms of upper respiratory infection and do not have a fever. A final croup mimic that you may see out there, although uncommon in an infant, would be an acute allergic reaction where they have angioedema or swelling of the upper airways, resulting in a lot of croup-like symptoms. These children typically may have other manifestations of allergic reactions such as hives, swelling of the lip and tongue, and they do not have a fever. So if you have a child where you're thinking about an acute allergic reaction, look at the other mucous membranes like the eyes, the lips, the tongue, see if they are swollen. See if you find any other symptoms or findings to suggest this could be an allergic reaction, in which case you would treat them with epinephrine. So what does croup sound like? So I've got a couple recordings, more so that have more so with stridor, but they also have a bit of that croupy cough. But I think a little audio-visual action might make this talk a little more interesting for you. So hear those noisy respirations? That's stridorous. Here's another one. Child's fussy. Got stridor with inspiration. So that gives you an idea of what stridor and a bit of a croupy cough may sound like. So I just threw up an X-ray because in the past we used these X-rays to discriminate between acute bacterial epiglottitis or acute viral croup. This is an X-ray of a child who has the croup, and it's kind of an anterior-posterior image, so front-to-back X-ray. If you look at the blue arrows, kind of the lower mid portion of the image, that dark column in the middle, that is the trachea. If you go up toward the child's head, you'll see it kind of becomes a pencil point or a steeple appearance where the red arrow is. So that's what we typically would see with a child with croup. It's the steeple sign or the pencil sign. And that's something that we'd use to identify a child with croup. And the reason you see it is because of that subglottic edema from swelling of the mucosa. So I just thought that'd be an interesting thing to look at. So if you look at the article, how do we manage children with croup? And the article talks about children with mild, moderate, and severe symptoms. Chances are for us, we're going to see children that have anywhere from the moderate to severe. We'll talk about our protocol in a couple minutes, but But this article talks about differentiating between mild, moderate, and severe. Child who's got mild croup, they don't look too bad. We tend to give them a dose of oral steroids. For us, that's dexamethasone, 0.6 milligrams per kilogram to a maximum dose of 10 milligrams. And with observation, we can send them home. I suspect if you evaluate a child with croup, you're going to assume they're moderate to severe severity. We're going to treat them with epinephrine and dexamethasone. But for the patient in the emergency department, we would give them oral dexamethasone. We'll observe them longer than we would a child with mild croup. If the child improves and has no evidence of retractions or stridor at rest, meaning if they're just breathing normally, you don't hear any noisy respirations, then we'll discharge them home with the mother or father, educate them in terms of what to expect without patient follow-up. If the child gets a dose of steroids and they really don't do well, we're going to watch them for 4 hours, and if they don't get back to a satisfactory condition where they're breathing normally and they have no stridor at rest, we're going to have them admitted to the hospital. And then the child who's severe, we're going to minimize any interventions, so we don't want to do anything that's going to make the child agitated, which will aggravate their illness. We'll provide some blow-by oxygen, although honestly there's a lot of controversy over whether or not blow-by oxygen actually works. And we're going to treat them with nebulized medication. You could use either racemic epinephrine or regular epinephrine 1 to 1,000. I'll talk a little bit more about the dosing of that under our protocol. In the past, we've carried racemic epinephrine on our trucks, but we took it out of the trucks because it required refrigeration, and we didn't use it as often as we thought we would, and we already have epinephrine on the truck. So in order to simplify our drug list, we removed racemic epi. But for the severely ill child, they'll get epinephrine nebulized or racemic epinephrine nebulized, and they'll get a dose of dexamethasone. And if the child's too ill to take it orally, they may give it either intramuscularly or intravenously. There's been some talk about giving nebulized steroids. That's not something we've investigated for use in the EMS setting. And then if the child with severe croup does well, they'll be observed for 2 to 3 hours, and if they continue to do well, they'll go home. If they rebound, which commonly occurs, then they're going to have to be admitted to the hospital. Occasionally we'll have a child who has such a severe case of croup that they fail conservative treatment with bronchodilators, with nebulized epinephrine and oral steroids, and they require intubation in order to preserve the airway and ventilate the child adequately. So again, this is kind of what we would want to know for managing croup. It's just a focused version of what I had on the previous slide. And again, we break it down into mild, moderate, and severe. What about our protocol? We have our pediatric respiratory distress protocol. It's been modified a little bit because we identified that we were underdosing children with epinephrine as a nebulized medication. But again, we identify the child as being sick or non-sick. If the child needs an artificial airway, we will follow our airway protocol. Otherwise, we'll have the child in a position of comfort and do what we can to keep the child calm. We can try some normal saline aerosol, but if you think the child has croup, we're going to proceed to give them an epinephrine aerosol of nebulized medications. This is where we've made a change to our protocol. It'll roll out in the protocol this week. We found that we were underdosing epinephrine when we nebulized it for croup. So we've changed the dosing to a 0.5 milliliter of 1 to 1,000 epinephrine per kilogram, up to a maximum dose of 5 milliliters, which is 5 vials of 1 to 1,000 epinephrine. And so any child who basically is 10 kilograms or more in weight is going to get the same dose of 5 vials or 5 milliliters of 1 to 1,000 epinephrine. And we'll dilute it with a little saline and then nebulize it. And again, these children have to be transported. Children who are treated with epinephrine or racemic epinephrine have the potential to rebound, meaning they get better, and then an hour or two later they rebound and get worse and need another treatment or need ongoing treatment at the hospital. So anybody who gets nebulized epinephrine is going to be transported. That's an absolute. My suggestion is if you think the child needs epinephrine, you start the treatment, but then at the same time you start moving the child out to the truck for transport. Another thing to consider is we're talking about 5 vials of 1 to 1,000 epinephrine. You may need to look at your stocking levels on your vehicles to make sure you have enough epinephrine in the truck to do this. So the 1 to 1,000 epinephrine is the same medication that we use for intramuscular injection for anaphylaxis. It's the 1 to 1,000. The cardiac epinephrine that we use for IV administration is 1 to 10,000. So again, you may want to look at your stocking levels on your trucks to see if you have enough 1 to 1,000 epinephrine available. So kind of a summary of our protocol. All Croupers get steroids. All of them get dexamethasone. The oral dose is fine. So if the child's able to take something orally, give it to them orally. We don't need to stimulate them or punish them by giving them an injection, and we don't need to start an IV if the only reason for the IV is to give them steroids. Always have that high index suspicion that the child may get worse, and they may get better with your epinephrine aerosol. And if you've got a long enough transport time where the nebulized or nebulization is completed, the child has the potential to rebound and get worse while they're still in your truck. Generally, we should use nebulized epi for moderate to severe cases, although if you have any consideration in transporting the patient, they probably should get epinephrine. And then again, all patients treated with nebulized epinephrine are transported. Start the epinephrine, then initiate the transport. And I think there should, and let the parents know up front that we have a treatment for their child, but it's going to require transport. So that's all I have for this month on Croup. If you have any questions, feel free to send them to me via Workplace. Next month, we're going to revisit allergic reaction and anaphylaxis. Dr. Stevens talked about this or did a MEC minute on this a couple years ago. We continue to see EMS runs for patients with allergic reactions or anaphylaxis, and they get all the treatment in the protocol except epinephrine. We need to reinforce that the first drug of choice for any allergic reaction is epinephrine, followed by all the other medications. But we'll go into more detail on that next week or next month. Thank you for your time.